The goal of this cadaver series is to show the anatomy, to maximize injections in the face, and to minimize the chance of any complications. Knowledge of the anatomy makes it so that complications are minimized and we have maximum efficiency with our injections. We're going to start out today with some general principles. One general principle is when injecting filler, we can use either a needle or a cannula. We can also use a perpendicular technique or a tangential technique. What I mean by that is this. If we are going to inject on the chin, we could use a technique that is perpendicular to the skin, such as this. We could also use a technique that's tangential to the skin, such as this. As you see it here, I'm doing this with a needle, but we could also do this with a cannula. Obviously, if we're going to use a cannula, we need an introducer hole with a needle that's just larger than the cannula. Another principle is that if we use a cannula, the longer the cannula, the more the pushing to get the product through. So a shorter cannula sometimes makes it a little bit easier. This is over 2 inches long. Also, the gauge of the cannula is very important. If you have a smaller gauge cannula that is long, you need a lot of pressure on the syringe to get product through the cannula. So shorter cannulas with bigger gauges make it easier to push product through the cannula. Additionally, when we use needles, needles often work well with a perpendicular technique, where cannulas are very good with a tangential technique. So those are the general principles when we inject filler product into the face. Having used that, we're going to think about various regions as to where we're going to inject into the face. So the goal of understanding the layers of the fat and the layers of the skin is to know what the thicknesses are and what specific anatomic structures will run on each layer. As we look at the face, we have a skin layer which is variable in thickness. The eyelid skin is the thinnest. Over the chin, the skin is much thicker. Also, the fibrous tissue that surrounds the fat just below the skin is different in different areas. We think of the face as having equal fat all throughout it, but that is not true. The face is composed of subcutaneous fat, which has a tela retinacular subcutis, which has some fibrous tissue in it, and that fibrous tissue is different in thickness in different parts of the face. As we elevate the skin off of the face, we can see that there's a fat layer just beneath the skin. And we can see this very nicely done fat layer. Within the fat layer are multiple small blood vessels. But the fat is different in composition in the forehead, where the fibrous tissue is a little different, and the holes where the fibrous tissue are bigger. And if you put filler into this area, it will fill up the holes and very easily fill up the areas where the fat is. However, near the eyelids, there is no immediate subcutaneous fat, and we can see here that there's no fat. The area is much different around the lips and around the chin. The fibrous tissue in this area is much thicker. The fibrous tissue in this area is much thicker. And that makes for a differential injection type when we do inject. We will go into a region by region injection of filler into the face. But to start with, general principles are that when we want to inject an area that involves improving an entire region, we may go tangential to the area with our needle or cannula being almost parallel to the skin, just tangential to the skin. However, when we want to augment onto a bony surface and we want to create either a pyramid or a column, we may go perpendicular to the skin. so that we go right down on bone. As a general rule, and these things are not hard and fast, but needle or cannula does very well with tangential injections. But perpendicular injections are very well served by needles, such as in areas like this. As a general rule, if we're trying to do a very superficial injection, because the attachments can be tight, this works very well to use a needle. And it usually works well to do this in a tangential plane. But if we're going down on the bone, in between or into the deep fat between layer 3 and 5, in other words, beneath this layer, we usually use a tangential injection, and this works well with a needle or a cannula. It certainly is a great area for cannula injection of filler. So the skin has been lifted in a lateral to medial fashion off of this cadaver, and we're looking at the subcutaneous tissue. We see many vessels here, and obviously every injector is afraid of a few complications that relate to vascular injections. One of them is local vascular necrosis and skin necrosis from getting some filler directly into the lumen of the vessel. The other is a retropulsion or a flow of that into intracranial arteries that can cause blindness. Both of those things are worries. So let's look at the vessels as we look at the cadaver. And purposely, we've not dissected out any vessels here. This is just as it shows on the cadaver when the skin only has been lifted up. Now, the thing that often gets taught is that a given vessel is in a single spot. For instance, the supraorbital is here, as if it's a single line that we can always see exactly in that area. That is not true. A vessel like the supraorbital starts deep on the bone, it pierces the corrugator supercilii muscle, and then it pierces the frontalis to run on the more superficial surface. So we need to know the X and Y position, that is, where the vessel is on a flat plane, but then we also need to know that the vessel changes planes. It's deep here, and it becomes more superficial here. So actually, in this area near the glabella, a superficial injection is relatively safer because the artery is deep. And in this area, a superficial injection is riskier because, as you see, here are all of the superficial vessels as they run on the surface of the frontalis muscle. A similar kind of thing can be done in the temple. In the temple, we are seeing the superficial temporal artery. This artery is one of the two terminal branches of the external carotid artery. It has a frontal branch and it has a parietal branch. Now, the interesting thing is the external carotid artery does not go into the brain in any way. And so one might ask, how do you get blindness with a direct injection into this artery? How would that happen? Well, if you look at most external carotid artery vessels, they have anastomoses with internal carotids. So let's use here, this is supratrochlear. That is an internal carotid system artery. Superficial temporal, that is an external carotid system artery. But they anastomose. So if some of the thing that we would inject gets into this artery, it can go in this direction down to the supratrochlear, that can get into the retinal artery, go intraorbital and then intracranial and cause blindness. And actually, I have seen many cadavers where the anastomosis is not just ipsilateral, but it goes all the way across to the contralateral supraorbital artery and supratrochlear artery. So again, in the temple, we have superficial temporal artery, parietal branch, frontal branch, and it comes up in this relatively superficial layer, layer 3, the temporoparietal fascia. It runs within that layer. You can see it's slightly covered by fat. If we took that fat away, the artery would be very noticeable, but you see it well here. But we have to be very careful with superficial injections to fill up a temple in this area. We have to be careful with superficial injections in the forehead. As we go down further onto the face, there are several other vessels that we see. An important artery in the lower face is the facial artery. This artery comes across the mandible in an area between the masseter muscle, which is just posterior to the artery, and the DAO, which is just anterior to the artery. All of the time, the artery is just anterior to the vein. They both cross together here. There are two areas that cross the mandible deeply together, just like this. The vein, after it crosses, is straight, and it proceeds up the face. And we can find the vein deeply, and it ends just at the inferior border of the orbicularis oculi muscle. That's where the facial vein is. If we draw a line from here toward the medial canthus, that's almost exactly where we find the vein, but the vein is fairly deep. The vein is also straight. It's difficult to cannulate the vein and put filler into it. However, the artery, which is just anterior to the vein, remember they cross the mandible, the artery is a branch of the external carotid artery, it becomes very tortuous and it goes toward the corner of the mouth. Before it hits the corner of the mouth, it gives off a branch that goes underneath of the DAO, and that branch becomes the inferior labial artery. The facial artery then proceeds a little higher, and it gives off another branch that goes underneath the LAO, or levator anguli oris, and it comes out underneath the LAO and is the superior labial artery. But then the facial artery continues up here and becomes more superficial, and it runs relatively in the groove, the melolabial groove, the cheek-lip groove. We call that the nasolabial groove, but it's more accurately called the melolabial groove. It runs along that groove, and it becomes very superficial and is somewhat naked. It's only in a little bit of fat. It's covered by no muscle. Down lower, these arteries are covered often by muscle, but in this region, they are not really covered by very much muscle. And the reason that becomes very important is that it is very easy with a superficial injection to put hyaluronic gel or another filler into that area. So an injection parallel and superficial can very easily get into the artery. Now, the superior labial artery gives a branch off called the columellar artery. And that artery gets very superficial. And if we're trying to build up the philtrum of the lip or put any filler in the lip to give it projection, there are superficial arteries here, and we're at a lot of risk in that area as well. And lastly, as we do an injection that is up higher toward the tear trough area, the tear trough being that concavity just inferior to the orbicularis, it's where the tear trough ligament is. If we're trying to fill that up, we have arteries here that occur on the lateral aspect of the nose, the angular artery. And we can see this angular artery that looks like it's discontinuous with the facial artery, and that angular is going to come down and give the lateral nasal artery in this area at the nasofacial groove. But this is the angular artery, so it's very easy to put product into that artery. So as we look at all the superficial injections, there are some areas that are very safe. For instance, some people behind their mandible have a little superficial deficiency just in front of the ear, this little preauricular area. This is a relatively safe area to be in the subcutaneous fat and put filler.